All right. Good evening, everyone. Glad you're enjoying the music. As I looked down, I said maybe I can wait till that song finishes, but it's like a 5-minute song. So anyway, thanks all for joining me tonight. So there's 28 of us on here, and I chose this topic because I think it's something that is very confusing a lot of times when people experience it. It's also very challenging as a clinician to treat this disorder that we're going to talk about. And it's very complex, and it's often misdiagnosed and not well understood. So I hope you guys enjoy the lecture I have prepared for you this evening. And as always, I welcome any questions. So I'll be keeping my eye on the chat window to kind of help engage. And if there's anybody who wants to speak, I can click on you and allow you to talk, and so we can have a little bit of a dialogue if you guys are interested. So before we get started, I'm going to actually read from one of the research articles that I used to put together this presentation, because I thought it was a really succinct definition of borderline personality disorder. And I might abbreviate that as BPD. You might hear me say that. So I'm referring to borderline personality disorder. And so here's a quote from that research study, and it is by Sable and Shore. It's in the references for this presentation, which you'll have access to as well. Mental health clinicians are increasingly confronted with patients whose intense emotions and persistent maladaptive behavior are challenging to understand and often difficult and frustrating to treat. Many of these individuals manifest a constellation of symptoms and behaviors which the DSM-5 defines as borderline personality disorder. These symptoms include severe problems in sustaining close relationships, with dramatic shifts from idealization to devaluation, self-destructive behavior such as substance abuse, suicide attempts and gestures, volatile feelings, unstable moods, and identity confusion. Along with impulsiveness and lack of self-control, there is an absence of empathy and cognitive awareness of their impact on others, which can lead to grandiosity, distorted versions of reality, and even to remarkable cruelty. In conversations, responses are vague, tangential, and over-personalized, with the affect and word usage odd. In treatment, affective instability and demands for special consideration and instant availability can be overwhelming. Etiological perspectives of BPD is conceived as a condition of profound insecure attachment, with extreme oscillation between attachment and detachment, between a longing for attachment and a yearning for secure affectional bonds, alternating with the dread and avoidance of such closeness. Working models show a lack of coherence, especially in relationships with others and in affect regulation. I know that's a lot, but if you start to think about, as you're hearing me talk, you might have reminded some traits of individuals that you know. But keep in mind, when we're talking about a mental disorder, we don't mean just certain traits. We're talking about these persistent traits that are in, as the study says, in a constellation. So they are together and they're persistent. And this constitutes the individual's personality. And what is personality? It's a way that we have adopted partially through genetic traits, through environmental experiences and learning, to interact with the world. Our ego, you could say, is a construct that we create in order to interface with the world. I say I'm Oscar and these are my traits, but those are also flexible because they can change from environment. And so that's true even folks who might have this diagnosis. And I know it's really, when I was putting this presentation together, I was really worried that I didn't want this to come across as we're making fun of people who suffer from this disorder, even though some of the traits are so absurd, it might seem a little comical but I wanted to try my best to preserve and respect and honor people who have this condition. And you'll see how it evolves and the kind of etymology of the disorder and where it comes from. And you'll start to kind of open your understanding and awareness and hopefully your compassion as to why people suffer from this. Sometimes in some cases, it is kind of a spontaneous expression of the individual, that's how their personality is. But in most cases, there is an underlying etymology and individual experience that the individual suffers, which will lead you to this kind of way of interacting with the world. And it's so prevalent, or prevalent enough, that we've been able to study it and can see consistent patterns of behaviors and reactivity. Does anybody have any specific questions before we go forward into our lecture? Okay, so we'll just get going. Okay, I was supposed to show you that when I was reading the quote, I forgot, so forgive me. But this image personified that the psychological injury that that creates this reactive formation in individuals is present in childhood for a variety of reasons that we'll get into. But first, let's get into what it looks like exactly. We've given an overall definition, and we're going to get into very specific descriptions of the symptoms, and then how those symptoms present and the dimensions of which they manifest. So it's as I mentioned before, it's a complicated disorder. And the core features are an intense fear of abandonment. And early in my career and training, I read a book, I can't remember the author right off the top of my head, but it's called I Love You, I Hate You, Don't Leave Me. And in some ways, that kind of personifies BPD. There's intense ideation of an individual. So you're my hero, I love you, you're amazing, you're the best in the world. And then very quickly, that idea shifts to demonization, where they'll say, you're the worst person. I can't believe I've never been treated so terrible in my life. You are disgusting, and blah, blah, blah. It kind of goes on from there. I was getting a call, so I want to make sure. I'm going to check in with you. Can you guys hear me? Somebody just type in yes or no. No, the link isn't letting me in. Okay, somebody's trying to get in. You guys can hear me? Good. Let me try to help one of your classmates. There's always technical issues. That's just the way it is. The good thing is you guys are able to get on. Okay, I did my best here. Okay, so moving right along. Okay, so assessing borderline personality disorder, though it's been categorized and kind of clustered in these four domains that you have to explore: affectivity, so emotions, and interpersonal function, so your relationship with others, especially intimate relationships, familiar relationships, work, school, those kinds of things, because these are people who kind of know you best. Impulse control, so when people kind of go into rages and things like that, or impulsively act, and that can presented itself in a range of different types of behavior, which we'll talk about, and then some cognitive features that are really interesting, and kind of where I think BPD gets its name, because it's a kind of ambiguous name, and it always confused me when I was studying it until I started working more and more with it, and then doing my own research and reviewing some of the literature, the newer literature, to help me better understand it. So in order to meet diagnosis, you have to meet at least 5 of the 9 specific criteria. So let's go through that criteria of these 9. The first one, frantic efforts to avoid real or imagined abandonment. A pattern of unstable and intense interpersonal relationships characterized by alternating extremes of ideation and devaluation. I mentioned that. Identity disturbance, markedly and persistent unstable self-image or sense of self. And we'll get into deeper explanations of this. Impulsivity in at least 2 areas that are potentially self-damaging: spending, sex, substance abuse, reckless driving, binge eating. Recurrent or suicidal behavior, gestures or threats, or self-mutilation behavior. Affective instability due to marked reactivity of mood. For example, intense episodic dysphoria, irritability, and anxiety, usually lasting a few hours and only rare more than a few days. So this is different than bipolar, which often folks with BPD are diagnosed with bipolar disorder because some of the symptoms look similar, but if you take a good history, you'll see that these change frequently. But of course, sometimes the patient is a poor historian, and so they'll give you an incomplete or inaccurate assessment. Because remember, these traits are functioning even when you're doing the assessment. So it can be take a little time to get a really good assessment here. Chronic feelings of emptiness, inappropriate, intense, or anger, or difficulty in controlling anger. Frequent displays of temper, constant anger, and then recurrent physical fights. And so a lot of times people say, oh, you have anger management issues. Like, yeah, you did a little deeper, and you'll see this constellation of symptoms that are persistent through the individual personality. Transient stress-related paranoia, ideation, or severe dissociative symptoms. And if you paid attention to the last lecture, we know where a lot of dissociative symptoms come through. Okay, I'm going to stop for a second and answer some questions. Let's see, chat. That's the question. Oh, where's the chat screen now? Okay, I don't see anything on the chat, but Laura has a question. Oh, hi, Laura. Laura is my colleague and peer. She's a licensed social worker, and she runs a social work program. So her question is, I have noticed when doing clinical work, BPD individuals often elicit strong emotions of empathy in me. Do you ever experience that? No, I would say I have the opposite. That I get very irritated by clients with BPD. So I have to really watch myself and really kind of keep in mind, be mindful of where I'm at. But I find some folks some clinicians are almost better suited to working to BPD. And I have done it in the past, especially when you work in addictions, you're going to run into a lot of co-occurring disorders with BPD. And I would say the better I understand the disorder, the more compassionate I've become. So I would say early in my career, I would get very irritated. A lot of times they end up in emergency rooms. We would see them often when I worked in the psych hospital because of the suicidal gestures or suicidal attempts. And so they're very frequent. Hold on, I'm getting another call here. Let's see. Okay, that was a student trying to get in. I don't know what to do. I want to troubleshoot, but at the same time, I don't want to leave you guys all hanging. So I'm back. So Laura's response was, I was either full of empathy or incredibly frustrated. Yeah, it can go those ways. And as clinicians, we have to pay attention to those things that are setting us off and ask why. And one of the things that I noticed is when you're working with borderline folks is that they're so volatile. It becomes very irritating because we are empathic beings, right? So if I hurt myself, like if I pulled out an envelope opener and stabbed my hand right now on the screen, your empathy neurons, in your prefrontal cortex would fire, and you might even grab your hand and say, oh my God, that would seem so painful. And so when somebody is kind of on this emotional roller coaster and you're like, what is going on? It's confusing, it's irritating, because it causes reactivity within you. So it's good to get good training and have a kind of a plan when working with folks with the disorder, because it's not always is easy. And I would say early in my career, I had a hard time with it. And then later, and I've seen a lot of folks in my private practice where it seems to be, I'm better at it. But what I do is I work really slow, and I'm really careful as to just building that relationship so it's as strong as can be. I ignore kind of the other things. I don't move too fast, because for a lot of good reasons, if we can develop a really healthy, strong bond, that can be very helpful for them to start to work through some of the issues that cause this this presentation and their personality. So getting back to the cluster here and affective symptoms. So what that will look like is affective instability. So their moods are going up due to marked reactivity of mood, lasting hours, but rarely more than a few days. These frequent mood changes appear to overlap with bipolar, but there are several clear distinctions, and that's the time and that's when they present. So these affective presentations will come on as a response to the environment, where folks with bipolar, they will go into these elation, these highs, these I can't think of the word right now, this manic high or these depressive lows, right? And those will happen usually in a more consistent pattern that lasts a lot longer. So these fluctuations will kind of jitter around, and they're very volatile. Where it's like a bipolar person will have a state of their mania that will last a few days, and then the depression could last for days, weeks, or months. So another difference is this persistent affect liability throughout their life, rather than just happening in discrete times. So it's persistent, this kind of way of being, And that's when we talk about personality disorders. This is a part of the person's personality. And while we can help through therapy and through awareness and through, deeper understanding and mindfulness, the individual can make certain changes, but they might have to kind of like pause and then go, oh yeah, this is part of that, and kind of work through it. It can be really challenging, and personalities take time to change, and think about how long they've been that way, and then just thinking, well, if you a few sessions are going to do it, it's not going to work out that way. The third difference is reactivity of mood. The moods of the patients are triggered by external events, like I mentioned, and are particularly sensitive to perceived rejection. Remember, there's a strong theme about that fear of rejection, failure, and abandonment, of course, because failure can feel like rejection, right? And then it doesn't have to be real. It can just be perceived, like they're going to leave me, or they're going to reject me, or they don't like. And so you might say something like, a person walks into a room of people and looks around and says, nobody in here likes me, I can tell. And that will tell you, unless they're able to read everyone's mind simultaneously, that has more to do with that individual's skewed perception of reality. And then the moods can shift between depression, anger, euphoria, and it's transient. So it's sliding around all over the place. Now, you don't want to diagnose anybody, first of all, yourself, and you definitely don't want to diagnose children or teens, because they have transient moods, because it has more to do with their development cycle, and we give people a pass. We give kids a pass and adolescents a pass. We know they're kind of just developing and they're kind of figure out their mind. So a lot of it has to do with that. Okay. So continue on these affective symptoms. So some of the studies and the research suggests that the negative emotions persist for longer and they're more intense in patients than healthy controls. Although that's not true for positive emotions. Wouldn't that be nice if it was, if they're just happier all the time? A second characteristic is the quality of the mood reported by the patient, that they describe this continuous dysphoria, high emotional variability, increased hostility compared with other controls. So that dysphoria or unhappiness is continuous and pervasive. Inappropriate and intense anger is the next affective symptom of BPD and is related to affective instability. So they just go fly off the handle. Chronic feelings of emptiness, something that was described in the research was a feeling as something is missing. Feelings of hopelessness, isolation, loneliness, symptoms of depression, fear of abandonment, and self-destructiveness. You can imagine what your life would be like if these were part of your personal makeup and made it really hard for you to maintain any personal relationships. Libby asks, what is appropriate age of diagnosis? Well, most of the research is done on people over 18. So when you're reviewing the literature, I mean, DSM has a criteria, I think it is 18. But I will say that folks can control some of these symptoms as they mature, depending upon their developmental experience. If they get involved in drugs and alcohol or other maladaptive coping, that interferes with development, taking responsibility, learning, growth. And so that can take longer. Let me see if I can't. I have another person here. It's not working. Okay. Any questions after we've gone over some of the affective symptoms? Oh, there's some questions here. That's an interesting. Professor Debenham said that she had read that BPD are basically traits developed from untreated PTSD symptoms. That's what I would say about that. That's an incomplete understanding of how the disorder developed. Now, and as if you'll watch once we get to the end of the presentation, we'll see. But they are closely related sometimes because of similar experiences. But I think that's a misunderstanding, and we'll get into why by the end. Okay. Okay, so the next cluster of symptoms are impulsivity. All right, patients with recurrent suicidal attempts or threats of episodes of self-harm are seen in between 60 and 78 of patients with this disorder have been shown suicidal behavior. More than 90% engage in self-harm. Think about that. So a lot of times when we see this, there won't be a good assessment of the individual, and then they'll misdiagnose them as having, depression or with suicidal features and things like that. And this isn't always the case, but it's a pretty high, the correlation. Okay, I'm getting a few questions, but let me get through this, and then I'll see if I can answer a few questions as we're going along. Persistent self-cutting as a way of regulating emotions is a characteristic feature of the disorder. Recurrent overdoses related to stressful events like drug overdoses. Recurrent presentation to the emergency department because of suicidal gestures. Almost half patients meeting the diagnostic criteria for BPD. That's like, you can see, you're starting to see it. And when I worked at the hospital, we had these folks that we would call frequent flyers, and these are the folks that more likely were borderline. And because of the way our laws are set up, if somebody makes a suicidal gesture and it's reported, they're gonna hold you on a involuntary hold, and that's no fun. And so, but think about the transient nature of the mood as we were exploring in the affective features. So then they're suicidal one moment and then they're not the next, and now they're stuck in an involuntary hold. So they've, for lack of a better way of describing it, your rights are taken away and you have to stay there until they say you're okay to leave. And this can be very jarring experience for anybody, no matter what your state is. Not being able to leave, it's like you're in jail. Impulsivity and self-destructiveness in BPD can encompass other behaviors like gambling, spending, binge eating, sexual promiscuity, and substance abuse is also frequent. Alcohol and substance abuse dependence are seen in more than 50% of patients with this disorder. Combined with substance use and BPD is associated with an increased risk of completed suicide. So that there is a higher risk in this population because of the substance abuse. And that's another thing. So you might see them coming in for treatment for substance use disorders, but there's just an inconsistency in how they present, and you'll notice it because it's very different from how other people present. Okay, so before we go on to those interpersonal symptoms, well, maybe because I think one of the questions relate to this, I'll go through these first, and then we'll talk about, I'll try to get some of these questions here. So the interpersonal systems are a pattern of unstable relationships marked by extremes of ideation and devaluation. Remember what I meant was, like, they're the most amazing person, now they're the worst person. They're an angel and now they're a demon. And so how does that happen? This same person and it's fluctuating, right? It doesn't, it's not like somebody broke your heart and you hate them, for the rest of your life. You're not going to go back to thinking they're amazing, but that transiency is present. It's one of the most important symptoms to making an accurate diagnosis. So this is one of the things, so pay attention when you're hearing about the interpersonal relationships. Because of the interpersonal instability, less than half of women with this disorder marry, and even less than have children. Frantic efforts to avoid abandonment. Clinical experience suggests that over time, some patients react to this fear by becoming isolated to protect themselves from potential abandonment. So just checking out from relationships so they're not abandoned. I know it sounds counterintuitive, but this is the reaction that they might take. And of course, all these symptoms aren't present all the time. Like, as I mentioned, it's 5 out of the 9 within these domains here. Patients also feel their, this is an interesting one too. Sorry, I think I'm skipped one here. Identity disturbance frequently and suddenly changing goals, beliefs, vocational aspirations, and sexual identity, as well as a painful sense of incoherence, like not knowing who you are. You might see this, and I'll give you an example when I've seen it as a college professor, where somebody was bright, ready to graduate, like they were going to, and then they just decided, I'm going to quit. And then this didn't really make sense to me. The more time I spent trying to advise the student, the more I started to see that this had more to do with something going on with them, they're psychologically than the program, the school, because they were there. There was no, they could just finish and then. So sometimes things might present like that as this identity disturbance. Patients also feel as if they're assuming the identity of other people whom they're close to. So I've seen this in cases where they will take on, like, let's say you have a friend who's British and you start talking like you're British and you were born in the United States and you've never even been to England, you know? So with that accent, with that British accent. Identity disturbance seen in this disorder should be differentiated from normal identity issues that you might see in adolescence. So like I said, as it's not, the cause is, you know, the effect isn't always the same cause. It could be, in this case, an identity issue that it just normally presents itself through development in adolescents and teens. Being unable to define an identity on one's own, and instead being dependent on an interpersonal relationship to define you. So that's another trait that might indicate some further exploration and assessment to determine if BPD is there. Frequent fluctuations or a sense of incoherence in one's identity with BPD are, yeah, sorry, this is a repeat. So, okay, I know there were some questions here. To your knowledge, can medication to treat bipolar disorder worsen symptoms of BP? No, I don't know that. I would say that medication can help treat bipolar and BPD, but if you don't get the right cocktail, you could, because the individual is so unstable already, that could exacerbate things, and I've seen that happen when I worked at the hospital. But the research isn't very clear on which medications are helpful for BPD. So the psychiatrist is going to have to work with the individual and see if they couldn't stabilize them. So so just to get them a little bit more stable affectively so that they can start working in counseling. Because if they're too unstable, talk therapy isn't very helpful. So a lot of times group can help because that social connection between the group can help calm and stabilize the person just from the kind of the social construct of group counseling. Are there personality traits that can help people navigate this better? I don't know if I understand the question, Natalie. Yeah, I'd have to, I don't understand the question. So if you want to type in something to further explain it, maybe I can answer that. Okay, we have another question here. Because they have such a difficult time with interpersonal relationships, would you consider this diagnosis a disability essentially that would prevent a person from working? No, because they have resources and faculties at their control. But I would say that first of all, yeah, personality disorders are not, they're not a reimbursable through insurance. And I don't know anybody who ever got that I can, usually the big ones are like schizophrenia, bipolar disorder that are, you know, pretty severe, that are able to get disability for. So I hope that answers your question. Yeah, so there's a question. Have you ever dealt with clients who are misdiagnosed and in this example have BPD? Yeah, so a lot of times it's bipolar they'll misdiagnose, and sometimes because bipolar can be oh, I see. Bipolar can, if you kind of have some sloppy diagnosis there, it can be a catch-all for lots of different things like PTSD and, you know, so sometimes, yeah, those things, and oftentimes the diagnosis isn't as important as the work you're doing with the client, as you as the therapist and the psychiatrist to maintain some kind of coherence and stability. Like we identify these disorders because they're present consistently throughout the population, and in a certain number, right? But the treatment is very unique. We have some research to support certain kinds of interventions can be more effective, but treatment is a very individual and unique experience, and it needs to be. Okay, so Natalie was saying, is there a strength or something? Yeah, I would say that people who have a very strong goal in life, like they are tenacious and they want to do something, I'll tell you, half of people in Hollywood are probably borderline. And I don't mean to sound glib, but if you're spending time around actors and actors in general, or entertainment people in general, they're nuts. And Prentice and Company excluded. I've seen so many folks, and I'm like, they're doing it. They're functioning in spite of their personality issues that these, because they have a specific goal in mind. And there's a great quote, I can't remember the source right now. This is that the pursuit of a dream heals a broken soul. And I believe that if you care about something strong enough, it will shape and change and form you into whatever you need to be to make that happen. And it might have the benefit of you improving your character and your personality, which is pretty amazing. So the overriding character is love and compassion, and that of course heals everything, right? And I mean that seriously and sincerely. So to tack onto that question, is there something within a strength or a character that could help them overcome it? Being open and aware, being introspective. Sometimes these things don't come naturally to us. That's why we go into therapy to help out. Yeah, it could be why so many celebrities use drugs, right? And then then a lot of people think, oh, it's because they abuse drugs. I'm like, no, there's this correlation between the drug use and then the disorder. And I don't think if anybody was like a professional actor or anything, they would agree with me right now. They'd say, yeah, I think I've probably seen a lot of that in my time. Okay, so going on to some of the cognitive symptoms, these are interesting. 40 to 50 patients with the disorder have brief periods of psychotic symptoms or disassociation. So psychosis is when you are not in the real, right? You are in your own delusional world where you're seeing things and hearing things that other people are not experiencing. You're in a psychotic state. Or disassociation, you're not present. Your mind is somewhere else. Or your consciousness doesn't appear to even be there, like people have just kind of checked out. Paranoid thoughts, auditory hallucinations, but these last much less than, and they're not as persistent when folks with schizophrenia. So these symptoms seem to be related to stressors, likely to be short, circumscribed, and either based in reality or total fantasy. Depersonalization, so the person feels unreal or altered in some strange way, like I feel like I'm plastic or like I'm artificial or something like that. You've heard these things. Derealization and illusions, that the external world is bizarre and unreal, or the world is fake, which are misperceptions of existing stimuli. So they take stimuli in a way, and then the paranoia or delusion, they fixate on a specific aspect of it, and then they kind of, this fantasy emerges. So we kind of talked a little bit about BPD and how it affects moods and relationships. But I think that an important thing to think about is folks with BPD are considerably more likely to be victims of violence, including rape and other crimes. BPD is overrepresented in studies of inmates, so people engaged with the criminal justice system who get incarcerated. They're overrepresented there. And then females appear to exhibit higher rates of borderline personality disorder, is oftentimes associated with a history of childhood sex abuse, perpetration of impulsive and violent crimes, comorbid with antisocial traits, and incarceration for domestic violence. So these folks can become the victims of terrible ordeals because of how they interact. And it's not, these are just some traits, but there are other traits too that are not mentioned that I've seen patterns of in my clinical work, and we'll get into some of that. 81% of borderline subjects history of trauma. So 71% physical abuse, 68% sexual abuse, and then 62 witnessing serious domestic violence. So let's think about, how does this happen? So these things happen to these folks, and then they seem to be highly correlated with the emergence of BPD. Well, when the world feels so unsafe, this reactivity, this kind of trying to make sense of a crazy world that you grew up in or your experience of, leads to this kind of fractured sense of self. And in that way, they're victims of some really terrible and horrific things. And the more I learned about this, the more compassionate I became about working with them, because like I said earlier, their fluctuating moods can be aggravating when you're trying to work with them, because they're tangential, they don't stay on topic, they don't oftentimes are reflective, because their memory becomes their enemy. So they don't have a good kind of narrative of their life, of their, the way they interact, because it's so inconsistent. That becomes a danger in itself to be self-reflective. So some reported risk factors for developing PTSD are pre-existing psychiatric disorders, adverse child experiences, lack of social support, low socioeconomic, lower intelligence, family history of mental illness, and or substance abuse. So this kind of speaks to Professor Debenham's question about, is it undiagnosed PTSD? And I would say people can develop PTSD as adults, having already formed their personalities, and this personality disorder isn't there. And then people don't all of a sudden become borderline after traumatic events. And it has more to do with childhood trauma. And when I'm training clinicians, one of the things I like to make sure that they're very aware of and understand that attachment disorders in early childhood grow up to be, if they're not treated, borderline personality disorders. And that can be that can be an early indication of the causes of BPD. So let's look at some attachment styles for children. A quick overview. We don't have a lot of time, so I don't want to run out of time. I want to make sure we have time for questions and things like that, and then get into some of the treatments that are available for BPD. So secure attachment style is a child who's comfortable in social interactions and intimacy, being held, being soothed, and they tend to form better relationships with others and solve problems. They're willing to try new things and explore independently. They have fewer extreme responses to stress because they feel protected. They feel secure because somebody's there watching over there. Insecure attachments are infants who experience negative or unpredictable responses from caregivers. So imagine your caregiver is addicted to drugs or alcohol, and they may have this really inconsistent or unpredictable response to your needs. They see adults as unreliable. They don't trust them easily. Children with insecure attachments may avoid people, exaggerate their distress, show anger, fear, and anxiety, and they may refuse to engage with others. So that's the insecure type. And then disinhibited social engagement disorder. So a classic sign of disengagement disorder is over-friendliness with strangers. So when there's no safe or consistent caregiver, they'll see anybody as a source of the caregiver. So they don't discriminate. Just like, okay. And you'll see this kind of blow itself up in BPD too. Well, people will trust. That's why I think a lot of times that idealization kind of comes in, like, oh, this person is a possible source of a resource for me for intimacy, for security, for a relationship and things like that. And I think it has more to do, like I said, an outgrowth of this. They may show little interest or desire to check in with trusted adults before leaving to a safe place. So they don't check in because that caregiver isn't necessarily somebody who's going to worry about their well-being. They may have not, so they might get into a situation with a stranger or kids with this condition. So little preference for trusted adults over strangers, and may seek out affection from people they don't know. And you'll see this with some kids who just like cling to you right away. You just like walked in and they're, so the disinhibited is the question for Natalie is, it's the lack of consistent caregiving. It's not having caregivers who can meet your needs consistently or at all. So the child is searching for a source of attachment, and anything will do. There is no discrimination, because a lot of times we learn to discriminate on what is safe and what is not as children by watching our parents or our caregivers, right? And they let us know through signals and through an attachment and a bond that your mother or your father or your caregiver can give you a look, and this child, this is safe, this is okay, this is not okay, and children pick up on that, just like pets do too, dogs and things like that. And then the reactive attachment disorder. So in infancy or early childhood is also failure to seek comfort from a caregiver. So because it's so it's so volatile, the experience with the caregiver, they don't know where to go to the caregiver or not for comfort. They may resist physical comfort from a caregiver. I've even seen some really disturbing videos of where the child is going to the caregiver but like not wanting to, and does not look at them, because it's a dangerous thing, but you need it, and that's the only thing in the world. So there's this dangerous person who's supposed to take care of you and has total control over life or death, safety, your happiness, your unhappiness, and you have no choice but to be in that situation. Imagine what kind of psychological torture that is to a child with very few resources and defensive capabilities at that point. So then you can start to see how this very unstable attachment style develops in your personality, and you're very untrusting or trusting. And so there has to be kind of cognition of the safety of a trusted individual when you're working with these folks. And that's why it's so important to work on the relationship, as I mentioned earlier. So kids with reactive attachment disorder display a variety of behaviors such as irritability, withdrawal, lack of comfort seeking, and not interacting with other children, and avoiding physical touch. And you can it's so heartbreaking to hear this. Like, this is the world that they are trying to survive in the way they can. Some symptoms of reactive attachment disorder, attachment disorder. Signs the child may have an attachment disorder include bullying or hurting others, extreme clinginess, failure to smile, intense bursts of anger, lack of eye contact, lack of fear of strangers, lack of affection for caregivers, oppositional behaviors like throwing tantrums, fighting, poor impulse control, self-destructive behaviors, watching others play but refusing to join in, withdrawal or listless moods. And if you look at this list of symptoms, you can equate them to the same symptoms that are present in BPD, but in kind of in a more adult form. I thought this was an interesting quote from another studies. In adulthood, the avoidance style is often bifurcated into a dismissive style, into which social emotional connections are avoided because of others are devalued, and a fearful style in which one avoids connection because of fear or rejection. It's so painful to think about this. This person avoids connection because of fear or rejection. And you're stuck in this loop, you can't get out of it. And every human being we're social beings, we're emotional beings, and we require connection to thrive. Okay, and so some more stats about BPD. And one of the things that I thought was really important was that if we identify an individual with BPD, that their significant other should be brought in for treatment with them. So important. So there's an understanding there, and imagine if you're in a relationship, how volatile that relationship will be and scary. Okay. So some treatments for borderline. Psychotherapy is important, as I mentioned, but it's so important with the bond with the therapist is very strong. And whenever I'm working with folks with BPD, I spend a lot of time explaining the diagnosis and also telling them that the basis of our treatment is going to be around developing a healthy, appropriate connection in therapy, so to best create a new way of functioning in a world that isn't the world that they grew up in, if that makes sense. So there's a very common, and it's a very well-known form of intervention called DPD, or DBT, dialectical behavior therapy. And it's surrounded by mindfulness, attentive awareness, paying attention to your body, paying attention to your reactions, you're learning how to control a lot of these skills, and learning to control your emotions, reducing self-destructive behavior. So really working on a lot of remedial skills to develop healthy emotional reactions. And a lot of times it's done in group, or there's individual work done through workbooks and journaling. It can be really effective, but it takes time, and it takes effort, and focused attention, because so often the individual with BPDs, the mind is just jumping and jumping and jumping. So learning, especially social and internal cues, are missed. Then there's CPD, which is kind of changing and accepting your beliefs and behaviors. We're very well acquainted with CBT, excuse me. I'm having trouble talking today, I don't know. Schema-focused therapies, changing the ways people view themselves, challenging some of these negative ideations of themselves, or the all or nothing thinking, kind of looking at explanations that are gradient, and instead of black and white, they're full of color and nuance. So develop a more sophisticated way of experiencing the world rather than, good or bad. Medications can be helpful in helping to reduce some of the emotional dysregulation, so that they can tolerate, because when you're in therapy, you're a lot of times what you're doing is confronting some of those intolerable fears and patterns of behavior, and learning new ways of dealing with those. And that can be a very painful process for anybody, whether you got borderline personality or not. And so sometimes medication can help. I would say, short term. I wouldn't want to keep anybody on medication long term. In some cases, it might be necessary, but in most cases, I think if you have a good psychiatrist that is willing to work with you, and you're, showing progress in therapy, then helping you learn to self-regulate without the presence of psychoactive drugs is an important part of that change process. Okay, so there's my references. So I think this is a really important one, especially because most people are unaware of it. So they'll say, oh, well, this person is like a psychopath or something like that. But you start to see where these patterns emerge from and how, and we've kind of related them to these childhood traumas, which create these attachment disorders, and then attachment disorders mature into this personality disorder. So I'd be willing to entertain any questions you guys have or comments. We have some time left, about 30 minutes. Anybody? What you'll start to see as I'm presenting these disorders, and by the way, if you take our mental health course in our bachelor's program, one of the 400 level courses, we'll go through all of these major disorders. You'll be presented with a case study of it. You'll write a case study, and then you'll write a treatment plan. So what you'll get is major mental disorders, including BPD, and you'll get a deeper understanding. And what you start to see is they all are related to one another, right? People who have had parents, let's say caregivers, who abuse them different ways, or abuse drugs and alcohol, so they're not present psychologically for the child, and they don't present as a good and safe and consistent caregiver. So then this chaos, this home that the child is growing up in, is reflected through the individual's character, right? Their personality comes out that way, chaotic, because that's what they came up in. And so you can see how a lot of these things are related to one another. And let's say somebody who abuses alcohol and becomes very violent as a reaction to that, and then they create, traumatized children or family members, or maybe they get a gun and kill somebody in the home, and now this is happening, or there's a suicide, and then how all these things relate to one another. And this is why it's so important that we all take care of our mental health, and when we recognize problems, we seek help for them. And if we don't get it on the first try, we keep going, because we become the stewards of one another. We become our brother's keepers. We create the world, and we make the world the way it is. I was at the gym today, and I saw there was another mass shooting, and I thought, Jesus, this is just going to keep happening until we start taking care of each other. Or maybe it will never stop. I don't know. Right? But I know that there are solutions to these types of experiences, because I've seen it when I'm working with patients. I've seen transformative processes and them have completely different, their life circumstances change tremendously just from some treatment. And it isn't always like for years. I'm talking months or 6 months or 8 months, and I see amazing results, because it's so painful for them to live the way they've been living. So there's a couple questions here. Are there different levels as in autism, or is it all or nothing? Yeah, so that's a different topic, but autism is what we call, a lot of times you'll hear people say they present if they're on the spectrum, because autism is a spectrum disorder. That means that those symptoms have gradient levels from mild to severe. So yeah, it isn't always all or nothing, for sure. And there's another question here: to treat BP, should someone pursue a specific emphasis in their program? Most programs are going to train you to be a generalist, but what I would say is that if that's your interest, your passion, whenever you're faced with the opportunity to do some research, like you're going to write a research paper about something, focus your article research on those topics, because that is going to turn you into a specialist on your own, if that makes sense. So if you're like, oh, I've got to write a big research paper and the topic is on addictions, I'm like, okay, well, I'm going to go addictions and the correlation of borderline personality disorder. So the more be creative in your educational experience so that you get the benefit that you're looking for. We have to provide some structure, but there's usually enough flexibility so you can do that. So I would say one of the things that interested me was trauma and addiction. So all throughout my graduate program, that was my thing. And then when I got done, I knew more about it than most people. And then I spent my professional time when I was licensed, either providing training, education, workshops, or going to specific training, education workshops about those topics that I liked. And so that then it honed me into kind of a specialty. Let's see. I think you're right. It can stop, but we need to be supporting parents. Isn't intimidating or as far as punishing. Yeah, so it's a hard thing, and I think Natalie's got response is that we need to support parents in a way that isn't intimidating or punishing. And sometimes the state, when they get involved, it can feel like they're punishing you. But at the same time, sometimes parents, they just can't be left to their children. It's too dangerous. I've seen it. I've seen parents that want their children so bad, as soon as they get them back, they're mistreating them again. It's like, and we're racked by this system. And the system, the state isn't a cultural system. It's a collection of rules and regulations that we have subscribed to as a society, but it doesn't represent culture. And I think our culture is lacking, is where the fill that needs to come in to provide us with a richer life experience. And in many ways, that's been lost. And that can be initiated by artists. Artists are the cultural creators. They create our cultures. They express our values, our beliefs, what we find beautiful, what we find abhorrent, what we find disgusting or interesting. And so through the expression of art, we can formulate a cultural fabric that is supporting us. And I would say if we just depend on the state to do that, there's a lot of holes in that fabric, and it's just not sufficient. So yeah, of course, the state isn't going to be like a caring, loving individual. It's rules that are written down, and they have to be, unless we write laws that way, which is very ambiguous. Can borderline personality be inherited at all? There are research that indicate that hereditary is a factor. It isn't the only factor, but it is. So there's some correlation there. Okay, some more questions here. Can a therapist work with a child who presents with trauma behaviors to lessen? Well, yeah, it's not a death sentence. Just because you have experienced trauma doesn't mean that's how you're going to grow up. We've all experienced trauma. Human beings have. We're wired to react to trauma and to thrive in difficult circumstances. Yeah, I would say that getting treatment to children. And this is one area the government is very generous in providing treatment to children, because they recognize that if they don't treat that symptom in that childhood, and that's why they offer a lot of support for children or for protected classes of people like children and elderly, so they don't create more problems in our society. Because if we can head it off by getting the child resources and support, they're less likely to be mixed up in the criminal justice system or all kinds of, because of course early childhood trauma leads to poor physical health too. So it becomes a greater burden, and the researchers know this, and the policymakers know this very well. And that's why if you look at how they spend their money, a lot of times, you can take your kid in for therapy, and if you're on a like Medicaid or something like that, and they have pretty generous services for those things. There's not infinite resource, but they do what they can. Okay, I'm just reading some other nice things that people are saying. Kim said, our identity partially lies in our culture and how we embrace and are embraced by that culture. Yeah, and so if you find it lacking in your own life, then I would suggest delving into whatever cultural past that you might have a connection to or interest in. And maybe that's, maybe you've been in, you don't have it in that way, but there usually are some things that are grounded in, and that can fill in and give you a richer life, a greater, more meaningful existence. I love expressing emotions into art. I've always had a hard time talking face to face about how I feel, but creating something can make it a lot easier. Wow, that is a great thing. And there are art therapists. One of the counselors that I supervise right now, she's a trained music therapist. So she uses like drums and bells and singing. And I mean, she's just phenomenal. And it's really interesting how she uses a lot of that thing, those kinds of tools to help people heal emotionally, because I don't know why I think my window's open. I'm getting like a allergic reaction to the outside or something. But I will use art. Written art is kind of my medium. So I'll use poetry and stories telling and things like that to help people work through their own experiences. So if something resonates, then I might have a story, and I've got a list of poems and short stories and even books that I'll suggest for them to read, and then have to do their own journaling, or they might draw me a picture of their trauma, or write a poem about it, or write a story or a letter to somebody who hurt them. And so that through that process, they heal through that artistic expression and creative act. It's really phenomenal. So I've noticed with my own circles, and this is a question for Monica, have experienced, seems that society as a whole, specifically millennials and Gen Z, is becoming more open to trauma and intentional with healing their trauma rather than toughing it out like past generations have advocated for. Have you experienced the same? And if you do you think it will have a positive impact on the mental health and addictions of the future? Yeah, I think so, but it also can lead to so I wouldn't say that people just decided to tough out trauma because they thought, there was no information. You know, when you're talking the generations that exist, they had the internet their entire lives. I didn't have the internet my entire life, and my parents had a lot less access to information than I did. So I think in your experience of now, if you don't take into account the technology that is available, it can seem like that was a choice, but what it was lack of understanding and information. So now that there's more information, and it's great to see that people can embrace that information and recognize I need something to help me through this, and what I'm experiencing is a natural reaction to something traumatic. But I'll also say that nothing can heal an individual but effort. So we have to put in the effort and the time and energy into it. I've had clients who do very well. I've had others that don't do so well. And I think a lot of times it has to do with how much they can marshal their resources to that aim of healing. And it's not easy sometimes. And sometimes it's so scary they back away from it, which is understandable, because these terrible experiences are brought up. But we have a lot better treatment too. A lot of times trauma, like we have something that's called trauma-informed care. That didn't exist even in my time that I was educated in my graduate program. That was something that I learned after kind of happenstance. I was already doing it in my own way, but then there was a formalized process for that. And so now we have a lot better, it's kind of like as medicine has evolved, people live longer, right? And people who have died under different circumstances now live. Well, there's a reaction to that, and there's consequences, namely that they're living through very horrific traumatic experiences that would have normally killed people. So you think about how battlefield medicine has evolved, and things that people would have died from before will live, but they have the experience to reckon with after they have survived, you know, the medical experience, the process of surviving that physical trauma and things like that. So there's a lot of things change, and so things will inevitably, they can make things better, and in other ways they can make them worse. And what I would say is that one of the things that is having a positive attitude towards life is very important, in spite of all the horrific things that happen. because it is a life and you're here. And if you're alive and breathing, you're one of the lucky ones. And so even if something bad has happened to you, there has to be a recognition of it's good. And because something's going to get you, you know. Now, that isn't to say we don't offer compassion and understanding and an opportunity for folks to heal, but it isn't going to come from anything magical. There's no pill. There's no intervention that is going to just, you know, every intervention that I know, and I've worked in different, I have many different things that I use working with folks from trauma. It still requires the individual to put in tremendous effort. Touching on mental health and suicide, what are some evidence-based programs that you know of? I don't know of any general ones. I know of specific interventions that can be helpful. The most important thing when you're working with somebody who has suicidality is finding something that some reason they want to live, touching it into their emotions, what is it motivates them to continue being here. And if they have a negative worldview, that can severely affect their desire to live. Yeah, Felicia mentioned MI, motivational interviewing. Yeah, that's one thing that we use in addictions, and it can help in, there are some protocols for suicide that utilize MI. I would say that when you're working with somebody who's very high suicidality, is that you have to be open to the possibility that this person might kill themselves and there's nothing you can do about it as the clinician. So I'm not afraid to talk about it. So I say, okay, look, this is something that you want to do, or you said you wanted to do, and I have a certain professional and moral and ethical responsibility to protect you the best that I can. But I also know this is your choice, and I want you to know that even though it's not something I agree with, I will honor and respect that choice to the best ability that I can. That means we can talk about your thoughts of suicide and your plans and things like that, but know that there are limits to what I can accept. And if I feel like you're at a high enough level to yourself, I'll call emergency services and have you taken to a psychiatric hospital. So you got to be really honest. And I think one of the things that I see, especially when I train clinicians, they're scared to talk about it. And I'm not scared to talk about it because I've had patients kill themselves, and it has nothing to do with me. This is not, I didn't injure this person. It is not my responsibility. It's my responsibility to do the best that I can. But ultimately their life is up to them, and I can't prevent that. It's a terrible tragedy and a terrible loss to our society, and it has a profoundly painful impact on people close to those folks. But as a clinician, I have to have some professional detachment from the individual. Otherwise, I might become nervous or fearful. And it's not that I am, I just have to control it to the ability that I can still function in the capacity that I can care for the patient, if that makes sense. And I want you guys to think about that, because it's something that's going to be more and more common, and you're going to hear it more, than you're going to see it more. And I don't know if this has to do with just kind of negative information that people receive, so they start to form their worldview around it and think the world is such a terrible place. But do yourself a favor and go out in nature, in the middle of nowhere, or some place where there's less people, where there's no buildings or roads and things like that, and take a walk. If you tell me this world is so terrible, you'll have this feeling of peace and serenity surrounded by nature, and you will recognize that its beauty and its wonder is here, and it's present. And my lack of seeing that has more to do with me focusing on myself than what is really happening. So this very narrow-minded view of the universe that it revolves around me. Yeah. Yeah, I could imagine being terrified that somebody might kill themselves, but it happens. It happens in different ways, lots of different ways. So I think it's important is that, the things that we fear the most are the things that we don't understand. So we have to spend some time to getting to know that demon, so to say. There's a saying from Hindu mythology, the Upanishads, that a, an unknown deity becomes demonic because we don't know that power. We fear it. So get to know with it, get acquainted with it, and then so that you can be ready to deal with it when you're faced with the experience, because it will happen the longer you work in mental health. And I see it with my new clinicians. I'm a clinical supervisor, so after grad school, when the folks get newly licensed, they have to be supervised for roughly 2 years, and some take a little bit longer to get their hours completed. And in that time, I noticed there's a big, so I go over, suicide protocols and procedures and things like that. And those protocols are really helpful, so we can say, okay, look, I did what I was supposed to do, and that was the best. Because thinking, sometimes you'll forget what you're supposed to do. And so I tell them, like, call me, call another peer, talk it out, come up with a plan and execute it. Because if you're panicking and you're nervous and you're worried, you're going to forget to do what you need to do. And that's going to you're going to make mistakes. And then you're going to be responsible in those areas. And that's why now it's been changed in the legislature that mental health clinicians, all of us, the entire spectrum, whether that's clinical mental health counselors like myself, marriage and family therapists, social workers like Professor Debenham, psychologists, psychiatrists, we're all required to take suicide training. So suicide, prevention, awareness, all those kinds of topics. Every 2 years, I believe it's every 2 years. It might be every year. Yes, it is true. Knowledge is helpful. And the more we share information and knowledge with each other, the safer we make ourselves. So we have a deeper understanding of what we're experiencing. Because I think the biggest thing that I've noticed when I'm working with folks is they think I'm the only one. I'm the only one that goes through this. And then they talk to them like, whoa, they go through this too. Okay, it's part of the human experience. And I think we become so isolated and afraid that people are going to know who we are, that we become disconnected from other people, and we don't have meaningful experiences, and our lives become empty. And this is what I'm so grateful for, the kind of work that I do, is that I meet people, I talk to them, we have very deep, intimate conversations about their life, about what they're going through. They're very open and honest about that, and I'm able to open myself up to be compassionate, to really listen, to deeply understand them in a way that being heard heals, and it really does. And that's all you got to do a lot of times. You don't have to, all this book work and stuff. Yes, we have to have this basis and understanding, and we use research to inform our clinical care. But at the end of the day, if you can connect with somebody, that experience of them feeling seen and being understood has a powerful healing effect. And that gives me my life purpose and meaning in a deep way that nothing knocks me down. I get sad and I have worries just like anybody else in the world, but I never feel like it's too much, or that I've lost faith in humanity, or that my future is bleak, because I think another day that I have an opportunity to be of service to someone gives me a tremendous amount of satisfaction. I think if I got hit by a bus tomorrow, I would think I had a good life. I had a life that was useful and meaningful to me, and it aligned with the values that I have as an individual. And this is what I love about the field. And I also love about teaching students that are interested in these types of things, because I find them to be very resilient, very caring, understanding, compassionate people. And it comes through in your coursework. It comes through in your messages to me, your posts. Those are the kinds of people that are interested in working with others and helping them. And that bodes well for the future of our society. When I see dedicated groups of folks like you sacrificing your lives to become someone who can be a helper in the field, I think, wow, what better model can we ask for of an individual to dedicate their time and their life and their efforts? So it's like twofold for me. It's like working with the patients and then working with folks like you guys, students who are interested in becoming these helpers and are interested in these things. Because some people don't want to hear about these things. A lot of times people, when they find out I'm a therapist, are like, I could never do that. I would never want to do that. It sounds terrible. I'm like, it's not for everyone. But I enjoy it, and I hope you guys will too. And my greatest hope is that the folks, the individuals in these groups that want to become therapists, or go as far as you can. You might decide, you know what, I don't like clinical care, but I do want to support missions that support them. That's fine too. There's always a place for somebody, because we need financiers to run our agencies. We need accountants. We need business people. We need leaders. We need administrators. We need all kinds of folks that are necessary to make these systems work. And if you decide clinical care isn't your thing, that's okay. Don't feel guilty about it. Find where your strengths are and your interests lie, and pursue those passions. And I think that's good enough. I don't think anybody needs to do something they don't want to do, especially in this country where we have so much prosperity and opportunity that anybody can go to college in this country, find a way to pay for it, and make the kind of living and profession they want, as long as they're willing to put the effort into it. That's a pretty amazing thing if you think about it. It's not easy. There's always going to be challenges, but I think it's worth it, especially when you consider other societies who don't have that opportunity. Okay. Any other questions? We're almost out of time here, but I really did appreciate everyone showing up today. There's a lot of us here, 37 folks, and thanks for Professor Demenham for showing up. And I appreciate all the questions and the responses. That was really great. And I hope you guys learned something and it piqued your interest. And if you're interested in getting this presentation and the references, which is one of the reasons we cite references, is so people can find out the sources of the information they're receiving. I'd be happy to send that to you. Just send me an email and I'll shoot you up a copy. With the end of the semester coming, I want to wish everyone best of luck. Study hard, do well on your finals, and look forward to the time that you get to rest and relax for a little bit and then start the semester again. It's important that we make opportunities to enjoy the rituals of our cultural systems. As I mentioned, those things really give us a lot of purpose and meaning and solace, and it's nice to come together with people you care about and enjoy yourself and celebrate life, because what in life isn't worth celebrating? Thanks all. And oh yes, before I leave, the passwords, before you guys are reminding me, let's see, what's a good password? How about tinsel? Like for trees, tinsel on Christmas trees. So tinsel's the password for this event. That's it. Natalie wrote it down, TINSLE. Tinsel. I'm gonna go buy my tree on Friday, and my friends are coming over to help me decorate. So everyone have a great rest of the week, and if you need something, please let me know. Again, the password for the event is tinsel. All right, I'm gonna sign off. If you guys need something, you know how to find me. Thanks. Good night.